So let's first talk about the unipolar or depressive disorders. This is just a visual. If we're talking about cyclical types of bipolar disorder, it's you can imagine a roller coaster. You're going high and then you're going low. And if the line is a typical mood or somebody who's kind of feeling neutral or normal, you can see the highs are mountains and the lows are valleys. Somebody who's manic experiences lots of highs. Somebody who's depressed, you see experiences lots of valleys or lows. And normal, we have a little, sometimes where we feel a little better and sometimes where we feel a little worse. And then the visual below shows you a really nice visual of bipolar depression versus unipolar depression. And the unipolar is the red dotted line. So depressive disorders are defined in your book as a disorder that involves experiences with an usually intense sad mood. And so like we talked about before, depressive disorders are down mood, and we will talk about the specific criteria in a moment. The features of unipolar depression are where the person feels more feelings of dysphoria, which is sadness, and not euphoria, which is a sense of elation. People will show 5 or more of the following symptoms for 2 weeks or longer. Their mood may feel sad, dejected, humiliated, miserable, or agitated. Motivation is where a person experiences anhedonia, anhedonia, where they're not able to experience emotion or pleasure. They may have difficulty getting out of bed or be indecisive. Physical or motor characteristics are moving more slowly, talking less active and productive, and disturbances in appetite. Some people eat more or some people eat less, depending on how depression affects them. Cognitively, people have very negative views of themselves. They usually, what I say is, beat themselves up in their self-talk. They're unable to concentrate and they're confused. And in order to be diagnosed with unipolar depression, you have no history of mania. In the DSM-5, there are 4 types of unipolar depression. The first is called disruptive mood regulation disorder. The second is major depressive disorder. The third is persistent depressive disorder. And the fourth is premenstrual dysphoric disorder. So here is just a visual of what I just talked about, the 4 different types of unipolar depressive disorders: disruptive mood disorder, major depressive disorder, persistent disorder, and premenstrual depressive disorder. You can see major depressive disorder has a number of subtypes, which are very interesting, and we'll go over those as well. So disruptive mood dysregulation disorder affects children ages 6 to 10. And so this used to be in a section on early onset disorders, but this has been moved to the depressive disorders. And so this is an early onset depression. It's chronic and severe irritability. And this is where a child has temper outbursts at least 3 times a week for 12 months in different settings. And so you would think kids around this age do show irritability, but it would have to be very repeatable in different settings over a long period of time. Between outbursts, children with this disorder are still extremely irritable and angry. So it's just kind of a chronic irritability and anger, which may be a child's way of showing they're depressed. This disorder affects 2 to 5% of children and adolescents. It affects males more than females, and research suggests that children are at risk of developing depressive or anxiety disorders in adulthood if they show these signs of this disorder in childhood. So major depressive disorder is what we commonly refer to as clinical depression. It is very intense, but it's time limited, usually lasting about 6 months. And your book defines it as periods of depressive symptoms that are called major depressive episodes. The criteria we use for diagnosing clinical depression is that the person has to show a number of these signs consistently for 2 weeks. And so the criteria, people have to show 5 or more of these symptoms. Depression most of the day, decreased interest in pleasure or activities, which we also call anhedonia. Significant weight loss, or also a person can have an increase in weight gain. Insomnia or hypersomnia, so somebody can sleep less or sleep a lot more. Agitation is where somebody feels restless. Retardation would be a slowing down. Fatigue or loss of energy. Worthlessness or guilt. Difficulty concentrating. Recurrent thoughts of death or suicide. And you cannot attribute these symptoms to a medical condition or substance use, and they cause distress or impairment. So many of us may experience, if we have experienced a breakup or a bad day, we may experience a few of those, but they don't last for 2 weeks or longer, and usually we don't experience 5 of those symptoms for 2 weeks or longer. And you can imagine if you're experiencing 5 of these symptoms for 2 weeks or longer, how it would cause impairment or distress. So the lifetime prevalence of major depressive disorder in the U.S. is about 17% of the adult population. So every year, 7% of adults receive a diagnosis of clinical depression, and most clinicians categorize 30% of these as severe. So you can see it does affect quite a significant number of people in the U.S. There are different subtypes of depression. The first one is called seasonal affective disorder, and this is where people develop the criteria that I've listed: the mood symptoms, the motivation symptoms, the physical, and the cognitive symptoms, usually 2 months in the fall or winter. And it's usually the lack of sunlight, which is believed to be a cause of deficiency in serotonin, and makes people feel very depressed, is called seasonal affective disorder. The treatment for this is something called light therapy or phototherapy, and you can get them now for fairly cheap. I just bought one called a Happy Light. They have special bulbs in them, and they cost anywhere between $30 to $100, and you sit in front of them for a certain period of time every day, and they are supposed to increase your serotonin activity. So there's also major depressive disorder with catatonic features, and this is where, as we've talked about catatonia, this is where people have rigid postures or excessive movements of their body that are peculiar. And so some people have this as a feature of their depression. So they have immobility or excessive physical activity that doesn't have a purpose to it, peculiar voluntary movement, or melancholia, which is just extreme sadness, or echopraxia, which is repeating the movements of somebody else. Postpartum depression has been more in the media in the last few years because of the Andrea Yates case. I don't know if you're aware of her. She killed, I think she had 4 children in the bathtub. And Brooke Shields also came out with postpartum depression. And postpartum depression occurs 4 weeks after a child is born. A person's mood changes following the birth of a child, and it can severely change. It can last for a few months to a year. About 8 to 15% of moms experience it, and it can be really devastating to women. And the longer it goes untreated, the worse it gets. And so many moms, a high percentage of moms, actually experience the baby blues post the birth of their child. Part of that could be just feeling overwhelmed. You have this infant, you're not getting a lot of sleep, your routine is upset, your independence is decreased significantly, and so there's all this excitement, and then the reality hits. For those people who may have a history of depression in their family, or if they're a first-time mom or a single mom, or if they've had a prior miscarriage, they're at risk for developing postpartum depression. And postpartum depression is where somebody experiences the criteria we've talked about for a major depressive disorder following the birth of their child. So they show mood symptoms, they show physical symptoms, they show cognitive symptoms, and sometimes the symptoms can be severe enough where the person imagines themselves throwing their baby out of the window or microwaving their baby. And then if these feelings go untreated, that can develop into what Andrea Yates is believed to have had, postpartum psychosis, where you might think your child has the devil in it, or you're trying to save your child. You have a break from reality. And so there have been some campaigns to get this information out to mothers, especially mothers at risk who are at risk because of their family genetics or stress, to developing this, to know about it and get treatment as early as possible. So I encourage you to watch at least a little bit of the videos on postpartum depression to learn a little bit more about it. So persistent depressive disorder used to be called dysthymia in the DSM-4. This is a chronic, less intense or low-grade clinical depression, and symptoms have to be shown for at least 2 years or longer, and this affects about 1.5% of the U.S. population. Here is just a nice chart that compares major depressive disorder with dysthymic disorder. As you can see, major depressive disorder, you need 5 or more symptoms. Dysthymic disorder, you need 3 or more. And major depressive disorder only takes 2 weeks of having those 5 symptoms. And dysthymic disorder, you have to have that for 2 years or longer. Premenstrual dysphoric disorder is a disorder that has just been included in the DSM-5, and premenstrual dysphoric disorder, or PMDD, is where a person experiences a major depressive disorder about 10 days before the onset of their period or menstruation. And so this happens on a monthly basis, and this is during what is called the luteal phase. And the luteal phase is where our hormones fluctuate significantly about 10 days before menstruation. And during this 10-day period, women with premenstrual dysphoric disorder experience a major depressive episode by showing 5 of the symptoms of depression. They may feel suicidal, they may feel unmotivated or down, or beating themselves up cognitively with the thoughts in their mind. You can learn more about the disorder by watching the YouTube clip. It's very interesting and very good. But the way you would diagnose this is you would have the woman record her moods over several months and see if you find a pattern in this behavior. And you can easily do this if you're interested in finding out if you or your loved one has this. You can track your mood on your calendar, or there are websites or apps for your phone called Mood Tracker, where you can track your mood over a period of time. For treatments, antidepressants work excellent, just like for depression in general, and also exercise and taking vitamins can help with the symptoms of premenstrual dysphoric disorder. So in the DSM-5, here have been the criteria that have been proposed. So the person has to have experienced at least 5 symptoms, and those start to improve within a few days after the person gets their period. At least one of the symptoms must be either 1, 2, 3, or 4. So the person has to have one of the 4 and a total of 5 symptoms. So mood swings, lability is shifting mood, marked irritability or anger, depressed mood, anxiety or tension, unusual activities, difficulty concentrating, easily fatigued, marked change in appetite, hypersomnia or insomnia, feeling overwhelmed, and physical symptoms, breast tenderness, swelling, joint, muscle, pain, sensation, or bloating. The reason why you have to have one of the symptoms in 1 through 4 is because that's a part of the depression, a major depressive symptoms. Also, it needs to cause the person significant distress, and not be due to some other problem. And let's see. And you want to have the person record ratings during at least 2 cycles. So what are the causes and treatments for depression? The first one is stressful events, and people can obviously experience the death of a loved one, moving to a new city. All can influence our experiences with depression. Part of that is if we all get anxious or nervous about starting something new, but if the stressful event or the loss is so significant that it causes these symptoms for 2 weeks or longer, then you might be diagnosed with a major depressive episode. You can do a Google search of stressful life events, and psychologists have rated different events by how stressful they are, and you can see if you are currently facing a lot of stressors. Genetics, there's also a strong link. twin family, adoptive studies all show that the closer the biological relative, the higher your risk of developing the disorder. Neurotransmitters have also been an attributable cause for depression. Usually what happens is you experience a stressful life event and this alters your neurochemistry, and so serotonin and norepinephrine can play a role in the development of depression. And so treatments include antidepressants, SSRIs and SNRIs. TCAs and MAOIs are older medications that have more lethal side effects and food restrictions. So you can read about those in your book. Hormones can definitely contribute to depression. We see hormones playing a role in postpartum depression and hormones playing a role in premenstrual dysphoric disorder. Brain regions can also be problematic. Specifically, the left side of the brain may be of the frontal lobe may be understimulated, and the right side of the brain could be overstimulated. And so brain regions could definitely be affecting your level of depression. Gender also plays a role. We know that women are diagnosed at much higher rates than men with depression. There are a number of reasons why that is. One thing could be our hormones, or just women have a coping style where women tend to ruminate or obsess about things, which exacerbates depression, whereas men tend to distract themselves. They go work out or they go have a drink with their buddies. The other thing is the symptoms have been really criticized as being more typical of female depression, and if we used more gender-neutral symptoms, more men might be diagnosed. So men, when they're depressed, more likely show irritability or cope with substances, and so if we use those as criteria, some have argued that men would be more diagnosed with depression. Age, young adults are at risk. Let's see. If depression is found earlier, it tends to last longer and have a poorer response to treatment, and places younger people at risk for self-medicating with drugs or alcohol. Ethnicity, more whites suffer from depression than African Americans. Some have argued that African Americans have more support and more of a community organization or support, and so that kind of buffers the development of depression. Let's see, behavioral causes and treatments. Some have argued that people with depression lack positive reinforcement in their life, and so one behavioral intervention is to increase the things that you love to do every day, and that should lift your depression. So again, we talked about stressful life events. The other thing about stressful life events is when we are under stress, a whole chain of events happens in our brain with something called the HPA axis, the hypothalamus pituitary adrenal axis. And what happens is this system, once it gets going, it starts to release the stress hormone called cortisol, and cortisol is what gears us up for emergencies, but it can also be toxic and lead to depression if we experience a lot of stressful events. So stressors can lead to the reduction of reinforcers. The person withdraws. Reinforcers are further reduced because the person's withdrawing more, so they withdraw even more, and so you can kind of create this behavioral, cyclical, stressful, depressive situation. Another thing that can cause people to be depressed is learned helplessness. And if a person repeatedly experiences stressful life events and they cannot have any control over it, or they feel like they lack control over it, this may cause them to give up and learn to be helpless. And really, that's what a lot of depression is you feel really helpless. And so Martin Seligman's the one who did the studies with the dogs and shocking the dogs, and you probably remember this from Intro Psych, where the dogs could not escape. And once he removed the gate so the dogs could escape, they just stood there and be shocked because they perceived a lack of control over the negative events that were happening in them, and they learned to be helpless. And so this can happen with depression as well. Biological causes, we talked about that already with the hormones, neurotransmitters, etc. And we also talked about the frontal lobe and the lack of stimulation on the left side and the overactive right side. Some treatments, apart from medications, newer treatments are transcranial magnetic stimulation that's been just approved by the FDA in the last year or two, and is now the only place I know that is actually doing it is Lindner Center of Hope, and you can watch this video about this, but it's where the physician takes a magnetic kind of like wand, and this stimulates the brain, so they would stimulate the left side of the brain and destimulate or deactivate the right side, and this has been found to be pretty effective with depression. The next one is vagus nerve stimulation. The problem with that one is it was approved in 1997. It takes 1 year before it begins to work, and it's invasive because the person's using this pulse generator to stimulate the vagus nerve that goes to the brain. It was originally used to treat epilepsy, but it found that it improves people's mood, and so it's almost like a pacemaker for the vagus nerve, and it stimulates things and tends to uplift people's mood. Cognitive treatments look at the thought process with clients and really challenging the negative self-talk. One form of cognitive treatment believes that people with depression have a negative view about themselves, about the world around them, and their future. So a negative view of myself would be, I'm terrible, I'm not smart, negative word about the world, everybody in the world thinks I'm dumb, and in the future it's never going to get better, people are always going to think I'm dumb. That's the cognitive triad, and so a therapist would focus on these negative views of the self, world, and the future and really challenge those. Is it true I'm really dumb? Is it true that the world really thinks I'm dumb? Is it true that I'll always be dumb? And really challenging those thoughts. Another thing cognitive therapists would do is look at cognitive distortions, and these are really interesting. And as we go through these and as you read about them in the book, identify the ones you do. We all do these, and the more you can keep track and stop yourself from doing these, the more your depression will lift and you'll feel better. So cognitive distortions are where you draw erroneous or negative conclusions about yourself from your experience. Overgeneralization is where you take a little event and you apply that to lots of events, so I got a C on my psychology test, so I'm just going to be average in everything that I do. That's an overgeneralization. Selective abstraction is choosing to focus on only the negative and dismissing the positives. And so selective abstraction may be that you people give you feedback, they give you lots of good feedback and a few bad, you tend to focus on the bad. Let's see. You can read about many of these others in your book, or you can click on the link and read about more. And they're very interesting, and like I said, it's good to keep track of them, and that will help you reduce your likelihood of doing these. So cognitive treatment, like I said, you identify and monitor your dysfunctional thoughts. You learn the connection between your thoughts, emotions, and your actions, and you learn to substitute these thoughts with more reasonable thoughts. Behavioral treatment is where you initially assess what are the frequency, quality, and range of activities and social interactions that you're having. You then implement a treatment. What social skills do you need to improve? How can you get yourself in better environments? How can you develop new behaviors?